Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned Padma Shri awarded Professor Dr. Mohan Kameshwara. Sir is MBBS, ELO, MS, ENT, FRCS, FAMS, DSC, and Managing Director and Chief Surgeon at Madras ENT Research Foundation, Chennai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is deafness in children, current status in management, and further direction. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you so much. Good evening to you all. And first of all, let me place on record my sincere thanks for this opportunity to share this evening with you all. And I have chosen a topic on deafness in children because I think it's one of the most important challenges that we are facing in our country. So, as we go on in the talk, you'll understand why this is so important. The uh, ability to hear is something which is being acknowledged and treasured for many years, for millennia in fact. At the top I have put a quote from Tirukural, which is one of it's a 2500-year-old treatise in Tamil, in which the author Tiruvalluvar says that the biggest wealth that a person possesses is hearing, and it's on top of it he double emphasizes it, saying that it is not only the biggest wealth, but it is the ultimate wealth that a person can have. Now, this may sound a bit strange because many people may think that sight is perhaps the most important thing. And one of the best quotes that we can get from a person who was both blind and deaf is from Helen Keller, when she said that, if she was given a chance to get back one of her senses, it would be hearing that she asked for. And she further qualified it, saying that blindness separates us from things or objects, but deafness separates us from other people. So this is the reason why that she wanted actually deafness to be cured and hearing to be cured more than even her visual loss. Hearing impairment is a silent malady. Generally, when we have a handicap, there is a sense of empathy in us. When you see a person who's handicapped, automatically we have an empathy for the person. So you see a person blind walking around with a stick, or you see a person who is physically challenged, limping around, your heart goes out to him, see how you can be of help to them. But deafness, unfortunately, is silent because there's no visible mark for it. So if you are, for example, driving your vehicle and you see a person walking in the road and you honk and he doesn't move, your tendency is to, first of all, you get angry. You think this man is arrogant, is he a mad fellow, is he arrogant? So you tend to shout at him and move. Yeah, but you won't think that maybe he's deaf and he's not hearing this. So it's a silent handicap and it elicits no sympathy. And very often it only, elicits ridicule or even derision. At extremes of age, hearing loss is even more important because it significantly impacts cognition. In adults, if you have an uncorrected hearing loss, it's the surest recipe for cognitive decline and early dementia. In childhood, if it's very important, hearing is very important for development of language and even more important for your IQ development. So, if a child has an uncorrected or undetected hearing loss, he has problems of developing language and communication. And on top of it, a very clever child who could be a potential Nobel laureate ends up becoming a dullard and is considered as being stupid. But of all the sensory deprivations that we have today, the only silver lining in the cloud is that hearing loss is perhaps the most amenable to correction, which is why it's so important for us to recognize the hearing loss. The hearing loss could be happening due to problems in the external ear, middle ear, or in the inner ear, or even in the auditory pathways to the brain. And congenital hearing loss is the most common congenital anomaly to affect children worldwide. Again, to emphasize, it is the most common congenital anomaly to affect children world over. All over the world, the incidence of congenital hearing loss is 1 or 2 per thousand live births. And in India, it is many times that number. In many parts of India, it is about 1 to 2, but in some parts of India, like for example, the southern states like Andhra and Tamil Nadu, it is even up to 6 per thousand live births, and that is because of the prevalence of consanguineous marriages in these communities. According to the WHO, the burden of hearing loss is simply phenomenal. It estimates that almost 10% of the world population, which is 630 million people, live with disabling hearing loss. Of these, 32 million, or about almost 5% of them, are children. And of these 32 million, 10% of them live in India. 7% of our school children have significant hearing loss, which is sufficient to impact their ability to learn. And as I said, the hearing loss could be anywhere in the external ear, middle ear, or even up in the ascending auditory pathways. Now, for a normal child who has normal hearing, there are certain clearly defined hearing and language milestones. In the first 3 months after birth, the child will often react to loud sounds and even make cooing noises. Around 3 to 6 months, it starts looking at the direction of sound and starts making some speech like sounds. From 6 to 9 months is the babbling stage when they say, words like mama, dada, and baba, and so on. And they often will respond to their own names when they're called. From 9 months to 1 year, they start imitating speech and they start understanding simple words like a doll or ball or daddy and so on. And also the first words start emerging. From 12 to 18 months, the child starts developing, even more with, pointing to people, to body parts or toys when asked. And they appear to understand new words with each week. Now, from 18 to 2 years, the child has much more development and it starts combining words into small phrases. From 2 to 3 years is an explosion of language when they start using longer sentences, more complex sentences. And from 3 to 4 years, they have really developed more or less, the full scope of their language, and even sometimes may have more than one language. So when there is a problem of hearing loss or any problem in the auditory system, and if a child is brought to me, then how does my mind work? Now, before that, to put in context, we have to understand that the tremendous changes which have happened in this field. About 40 years ago, when I was a young ENT surgeon who had just graduated after my MS, if a child was brought with hearing loss, my heart would sink, really sink. If this child had a conductive hearing loss, then yes, I could correct it. But if this child had more often than not a profound hearing loss due to a problem of the inner ear, then there wasn't anything that I could offer. At best, I would give the child a hearing aid, which very often did nothing, and then put the child into a deaf school where it would go into a special stream of signing and so on. These children were literally condemned for life. But today, the scenario is different. If a child is brought to me today with profound hearing loss, I can look at the parents straight on their face and tell them, look, your child has profound hearing loss, but I can correct it. Give your child hearing and give him a future. He can be anybody he wants in the future. He could be a doctor, he could be a lawyer, he could be a scientist, he could be a world leader, he could be anything. So this four decades has seen this huge revolution, and which is why we have to be aware of what's happening in this field, because it's one of the most successful stories in the entire spectrum of medicine and healthcare. So today, when a child is brought to me with suspicion of severe to profound hearing loss, what are the thoughts or what are the questions I ask myself and I need to clarify? First of all, I need to know whether actually the child is having a hearing loss or is it only the suspicion in the minds of the family. Secondly, if possible, determine the cause. Third, where is the problem? Is it in the external ear, middle ear, or inner ear? And the severity of the problem. And finally, I need to know whether it is just the hearing loss alone or is it part of a larger syndrome. So all these questions have to be answered. Now let's look at the first question. Does a child have hearing loss? If so, how severe? So evaluation of hearing today has come a long way. We have tests which are subjective, where we need the cooperation of the child, and objective, where even if the child is sleeping, we can still do the test. Of course, these tests are more challenging in the very young children, let's say from 1 month to 2 months or 3 months. But by 3 months of age, we can have an accurate diagnosis, which is very reliable about the whether the child has got a hearing loss, and if so, what is the severity of the hearing loss. So we have a rule today which is called the 136 rule. At 1 month, we start testing the child. At 3 months, we have already made an accurate diagnosis, and by 6 months, we should have started intervention for correcting of this problem. The second question is, where is the lesion? Is it in the external or middle ear, where it would lead to a conductive hearing loss? Or is it in the inner ear or beyond, where it would be a cochlear hearing loss or a problem in the central auditory pathways? This is known as sensory neural hearing loss. But the word sensory neural does not accurately reflect the actual position. Sensory, in other words, problem in the cochlea, is 99% of these problems. Only in 1% is a problem beyond the cochlea, either in the nerves or in the central pathways. So, majority of the sensory neural hearing loss is cochlear, which is a good thing because that's something that we can correct today. And in a small proportion, you can have a combination of both conductive and sensory neural hearing loss. Of course, the next question is the hearing loss a standalone problem or is it part of a larger syndromic event where other systems are also affected? If you have 10 children diagnosed with congenital hearing loss, at least two of these 10 would be syndromic. In other words, one more system or two more systems could be affected. And the commonly affected systems include the eye, the heart, the kidneys, thyroid, and so on. Also, keep in mind the next most common congenital anomaly after congenital hearing loss is Down syndrome. And in Down syndrome, at least 50% of Down syndrome babies have significant hearing impairment. So let's take conductive hearing loss first. This is a problem either in the external ear or in the middle ear. Here are some examples of a large perforation in the drum or cholesteatoma and so on. And it can happen most commonly in children who develop effusion or fluid in the middle ear, usually following an upper respiratory infection, nasal allergies, and so on. It can also happen in adults, of course, usually following a barotrauma or after a flight. But in children, it's very common and it can happen usually in the winter months and when they have allergies or upper respiratory infection. You can also have chronic suppurative otitis media, or you can have congenital causes like Down syndrome, cleft palate, Treacher-Collins syndrome, and so on. Simple problems like an impacted wax in the ear. The most common cause of this is parents trying to clean the ear with earbuds. So normally the ear wax is secreted, and there's a natural mechanism for this to move from inside the ear canal outside and then come out. When you try and clean it, you actually push the wax back into the middle ear and it builds up and may completely occlude the ear canal. So the best way of keeping the ear clean, paradoxically, is to leave the ear alone without any cleaning. You can also have occasionally trauma or foreign bodies. So management of conductive deafness, generally, when we have things like effusions, initially we treat it medically, at least for about 2 to 4 weeks. And only if medical management is not successful, then surgery is required, which may involve putting a ventilation tube called a grommet in the drum to drain the fluid and ventilate the middle ear. Occasionally, mastoid or tympanoplasty surgery for correction of diseases of chronic otitis media, and then you can have implants also put in. We'll talk about it. Here's an example of the ear with effusion. You can see the amber color of the drum. Normally, the drum is pearly white, and when you have an amber color like that, it means that there is fluid in the middle ear. And here you can also see a ventilation tube kept in the eardrum. It will stay there. It's called a grommet. It will stay for a few months and it will get extruded. Occasionally, if this tends to be recurrent, we put in a long stay grommet, which is what you're seeing in the lower image here. It's known as a T tube. Sometimes, if a chronic ear problem is not correctable by simple methods, then we use a bone anchored hearing aid where a device is fixed to the skull and it tends to pick up sounds and transmit to the inner ear through the skull. And this may include a situation like this where you have absolutely no external ear or middle ear, the congenital, meatal atresia with congenital absence of the ear canal and the external ear, or very resistant chronic otitis media and so on. And middle ear implants today, we have a whole lot of implants which can be used and they give excellent hearing as long as the inner ear or the cochlea is functioning. Now, coming to the more common sensorineural hearing loss, as I already said, it's the commonest congenital anomaly, affects 2 out of 1,000 children and even up to 6 per 1,000 in some parts of the world. Of them, most of them are due to a defect in the cochlea where the hair cells responsible for hearing are damaged. Once they are damaged, they are permanently damaged, they don't regrow. One of the big advantages, of course, is that the cochlea is fully developed at birth. It's adult size at birth. So, therefore, any intervention we do is for life. In general, we have what is known as a 60 to 40 rule. That is, if you have children, 100 children with hearing loss, about 60 of them will have mild to moderate hearing loss, and 40 will have severe to profound hearing loss. Of these severe to profound hearing loss, 60% of them would be congenital, and 40 of them would be acquired. So, what are the common causes? Congenital anomalies, vast majority of them are due to a recessive, autosomal recessive inheritance. A small number of them could be syndromic. Acquired causes include intrauterine infections, ototoxicity, prematurity, hypoxia, kernicterus, meningitis, and otitis media. Of the congenital sensory neural hearing loss, 70% are non-syndromic and vast majority of them, as I said, are autosomal recessive. Only about 10 to 20% of them are autosomal dominant. Of the syndromic hearing loss, there are several syndromes which have been identified where hearing loss is part of it. The most commonly involved organ systems are the eyes, the kidneys, the heart, thyroid, and occasionally craniofacial or skeletal abnormalities. These are some of the common syndromes. In India, the most common syndromes we see in association with hearing loss are the Usher syndrome, which is a terrible disease because these children become gradually, progressively blind also, and they also have deafness. So it's a double disaster. JLN syndrome is a very serious problem of conduction defect of the heart. where you can have a long QT. The corrected QT or QTC is usually above 500 milliseconds. These children can go in for sudden death due to ventricular arrhythmias, ventricular fibrillation, and so on. Pendred syndrome, where there is an associated thyroid anomaly with the goiter, Alport's can present later in adult life, is an X-linked recessive disorder, but you have a renal involvement, and there are some other rarer syndromes. What are the risk factors for sensory or hearing loss? Intrauterine torch infections are still a very important problem in India, particularly with rubella and cytomegalovirus. Craniofacial anomalies, when you have a birth weight of less than 1.5 kg, prematurity, hyperbilirubinemia, bacterial meningitis, and of course, when the upguard is poor and the child needs mechanical ventilation for more than 5 days, and autotoxic medication, and occasionally head trauma. Hearing loss can also be sudden and usually follows viral infections like mumps and meningitis, trauma. It could be occasionally idiopathic, following autotoxic drugs. And sudden hearing loss is an ENT emergency because if it is identified immediately, then it can be treated and even reversed. But unfortunately, in children, this history is often not forthcoming and it is usually missed. And when you have a hearing loss, I said that today it is amendable for correction, but we need to qualify the statement. This is a time sensitive issue. If you want to correct hearing loss, you have to do it early. And the reason for that is hearing is essential for language acquisition, cognitive development, and development of social skills and communication. And if it is not done early enough, then we miss out significantly on all this. So, how do we evaluate a hearing impaired child? First of all, the history is extremely important. So, you have to get a history of parents, of the are they consanguineous in their marriage? How was the antenatal period? Was it anything important? Was there any history of drug intake? How was the delivery? Did the child cry immediately? What was the upguard? What was the birth weight? The immediate perinatal period? Was there any ventilation involved? Was the child in NICU? What about the postnatal development? Were the other milestones normal? Was there any significant problem needing hospital admission? History of fever, history of convulsions, and so on. So we need to get a very detailed and thorough history, a complete ENT examination. Now, an evaluation is by a multidisciplinary team since it could be syndromic. So we need to have, of course, an ENT surgeon, a pediatrician, an audiologist, and other specialists, including a cardiologist, an ophthalmologist, a general pediatrician. Everybody has to look at the child and then do their bit to rule out any other problem. And of course, a clinical psychologist to evaluate the IQ of the child. Genetic counseling today is extremely important, genetic evaluation and counseling, because there are many, many syndromes which are genetic, and also identifying the gene also helps us to prognosticate about whether this child is going to do well with intervention or not. So, several investigations today. We have a whole series of audiological investigations, right from behavioral audiometry, pure audiometry, and so on, auditory brainstem responses, autoacoustic emissions, and then to test whether a hearing aid is helpful, we do what is known as an aided audiometry, where we fit a hearing aid and see how much hearing the child is having. And of course, imaging is very crucial. We need to have both an MRI and a CT to show the development of the inner ear and the nerves. And as I said already, other investigations to rule out syndromic association. So, how do we correct the problem? So, here today we have the option of hearing aids and implants. And implants could be bone conduction implants, which are useful in problems of conductive hearing loss, cochlear implants, and even brainstem implants. These are of help to us in sensorineural hearing loss. So, mild to moderate hearing loss usually entails a hearing aid, occasionally a middle ear implant. But when you have a profound hearing loss, then the solution is often a cochlear implant. Hearing aids are today, they have come a long way. We have very intelligent hearing aids, which can be very helpful. They are digital hearing aids. They can be tuned specifically for the hearing of each individual, and they have all sorts of features, including noise cancellation, directional hearing, and so on. So they can be very, very helpful in people who have residual hearing. But in the past, when they had a profound hearing loss, he had, as I said, no recourse. He gave them usually useless hearing aids and went then to sign language. The sign language is of no use today because these people become special people. The idea of any rehabilitation is to fit the person who has undergone rehabilitation, fit them into normal society. If they cannot fit into normal society, then they are not really, properly rehabilitated. They have not achieved the goal of rehabilitation. And this was again, a Kural which came from Tiruvalluvar 2,500 years ago, who said that if somebody may be very, very educated, but unless he fits in with society, he is considered as being useless. So today is the era of neural processes. What are these neural processes? These are devices which help to restore a lost or a deficient neural function. And this is done remarkably by integrating an external circuit with the complex neuronal circuits of the brain. This is an absolute miracle, and it's one of the greatest developments that we have seen in the last 2 decades. When Bill Clinton was the president, he used to have breakfast meetings with intellectuals. In one such meeting, he called the members of the American Academy of Medicine, physicians, and then had a breakfast meeting. And he posed a question to them. And he said, what is the most significant development which happened in the last 2 decades? And surprisingly, the answer was cochlear implants. Why? Because of several reasons. It is the first successful human effort to get back a lost special sense. It is also the first time that we have been able to integrate an external electrical circuit or electronic circuit with the neuronal circuits, thereby producing a bionic device, the first step towards a bionic man. And also, it is a significant innovation because today, several hundreds and thousands and millions of people have restored their hearing loss, and got back their hearing because of this device. So it is nothing short of a miracle, and it has changed our whole perception of how a deaf person should be managed. Of course, in India, there's a huge problem. It's a huge country, we all know, the most populous country in the world. And we have today a paradox where we have a growing middle class, where people are quite affluent, they have economic independence, but we also have simultaneously millions who are living below poverty line, who cannot afford standard care, health care, and the cost of health care. So the dilemma that we face in our country is to balance an advanced technology which comes with its own price tag with the requirement of a developing country. In the 80s and 90s, the situation was pretty bleak. We had very few schools for the deaf, and they were mostly in big metropolitan cities. So the vast majority of the children who were born deaf in our country did not have access to any form of habilitation. But all this changed. And we also had other challenges. We had, of course, the cost was phenomenal. When we started cochlear implants in the 90s, the cost of an implant was around 6 lakhs. And in 90s, 6 lakhs is almost equivalent to 60 lakhs today. So how many people could afford it? Because we had technology which could correct deafness, but the biggest hurdle was that it could not be given to the majority of the people who needed it. Add to it the problem of distances. If I was doing cochlear implant in Chennai, what about a person who is 500 kilometers from here or 1,000 kilometers from here who has to travel all the way? And after the implantation, I'm going to insist on his staying here for habilitation for a year. Would this be possible? And then the problem of multilingualism. What happens to a person who comes from, let's say, Jharkhand to Chennai? How do we have the habilitation for them? Deep-rooted cultural prejudices. Many people have prejudices against scientific medicine. And consanguinity is still widespread. It's the most common cause of congenital abnormal deafness, but it's still widespread in many parts of the country, and we are very helpless to try and stop it. So all these challenges we had to overcome when we started cochlear implantation in India. But from 2000 onwards, the scenario gradually changed. And the most important reason was that the outcomes were becoming more and more common. People started seeing the good results. And also, the Indian economy improved and people had more spending money. The attempts at electronically stimulating the brain has been going on for quite some time, even almost 2 centuries ago. It was tried. Volta, whom we all know, who developed the first battery cell, stimulated his own ear, and he said there's a sound of water rushing in his ears. But today we have much better technology and the ability to stimulate the cochlea specifically. The brain is also unique in that the auditory brain is quite unique. It has organization. If you look at the whole brain, it is an organized chaos. It is organized at the cortical level, but it's chaos at the neuronal level. But in the case of the auditory brain, there is something called tonotopicity. Basically, it is the ability to have a place corresponding to a pitch. It's like a piano. So if in a piano, you play the key on the left side, you produce low notes, and on the right side, you play the note and you get high notes. In the cochlea, it's like a huge piano, but upside down or ulta piano. The base of the cochlea, if you stimulate, you produce basically high frequency notes. And towards the apex, you produce the low frequency notes. So when you put in an implant and you stimulate the cochlea, you play this auditory piano and you can produce sound. If you play it fast enough, you can produce music. And if you can play it super fast, you can even produce speech. So this is the principle of a cochlear implant. So let's see
Of a
this
cochlear
cartoon
implant,
which will tell
we
us
will
about
follow
the
the path
cochlear
traveled
implant.
by any sound under normal conditions. The sound wave travels through the ear channel and reaches the cochlea via the middle ear. In the cochlea, the sound wave is transformed into electrical pulses, which travel down the nerves to the brain. Then the sound is processed. The sound is transmitted at a high speed. It plays an important role in the complete hearing process. The cochlea consists of 3 little channels filled with fluid. The incoming sound wave travels through the fluid and stimulates thousands of hairs on the top of the hair cells. The hair cells convert the mechanical energy into electrical impulses which stimulate the nerve fibers. They form the acoustic nerve which sends the message to the brain. The low sounds stimulate the top of the cochlea, and the high sounds stimulate the base. the hair cells are partially absent or damaged, hearing is reduced and deformed. This can be helped with conventional hearing aid. When the hair cells are completely absent or damaged, deafness occurs. Usually the nerve fibers are intact, but they cannot receive electrical impulses. In this
This is a situation where a hearing aid won't help and a cochlear implant comes in. So, cochlear implants basically is a system of electrodes which are surgically implanted into the inner ear or the cochlea. The external device collects the sound. It's known as a sound processor. It processes it and it stimulates the implanted electrode by radio frequency messages. As I already said, the cochlea is adult size at birth and therefore it's very helpful for us. So, who are the people who can receive cochlear implants? Any child who's got congenital deafness below the age of 6 can receive a cochlear implant, although the best results are those when we do below the age of 2. And also today we are doing more and more implants on children who had difficulty initially 20 years ago we couldn't do, but today the indications are really expanding. We're doing bilateral implants at the same time, both ears. We're doing in people who have single-sided deafness, all sorts of things which we did not do 20 years ago. Of course, all adults who have heard and lost hearing, who don't benefit from hearing aid, can also get back their hearing with a cochlear implant. The only prerequisite is that you have a cochlea and a functioning cochlear nerve. So investigations, of course, are imaging to find out if the cochlea and the nerve are present. And also, audiological investigations, as we already talked about. Medical evaluation, I already emphasized the need for all the ruling out all the syndromic associations. So a complete history and physical examination where a pediatrician is very, very crucial in the team. And also ophthalmologist, cardiac evaluation, anesthesiologist, all of them have a role to play in this. So it's a team approach where we need an otologist or ear surgeon, you need an audiologist, a habilitationist, and then you have the other pediatrician and then the other specialists who also report. And then, of course, teachers in education institutions who are trained to habilitate these people, psychologists, and the family is perhaps the most important in this team. So surgery is a straightforward microsurgery where we open the mastoid, we make a window into the middle ear and into the cochlea, and then open into the cochlea and then introduce the electrodes into the cochlea. So how are the outcomes? This is a child 1 year after implant.
Hello. I'm fine. How are you? I'm fine. What is your name? What is your name? My name is Yash. Oh, good. What are you doing? I am playing. With whom? Okay. Okay, say the shloka. Tvameva Mata. Tvameva Mata. Shabita. Tvameva Pantu. Jasaka. Tvameva
So this is Yash 1 year after an implant was undergoing habilitation. His speech is still not perfect. But today, this is a video taken more than 22 years ago. Yash is an IAS officer and he speaks 3 languages. So that's the potential of early intervention. This is my favorite picture where you can see a cochlear implantee whispering to another implantee. The one who's whispering has got sufficient language to whisper, and the one who's listening has got sufficient hearing to listen to the whisper. So this picture says it all. Now this is another situation where a child has got Usher syndrome, where it can become deaf and blind. This girl Afrina was implanted at the age of just 1 year and
Hello.
2 months. You can see the habilitation going on.
Dongle. Yes, very good.
That's the habilitationist and the mother.
Yes. Hello, good.
So this is Afrina after 5 years. She's a grown-up girl now. She's almost blind. She's got tubular vision. She's rapidly losing her vision, but her hearing has come back. She has developed language, and at least she has now that faculty with which she can blend with the rest of the world and communicate with the world. So this is a cochlear implantation is really a great boon for children with multiple handicaps. So in Usher syndrome, even if they become progressively blind, if they you do intervention at a sufficiently early period, then they can develop language and at least fit in with the normal society. The future, of course, is very bright in cochlear implantation. One of the areas of very, very active research. Every day, new work comes out, and we are having a lot of new developments happening as we speak on. Genetics is also becoming a very important development role, and we are now seriously now thinking about introduction of gene therapy, and we have had a successful situation where in one particular case the gene correction has also restored hearing loss in some small group of children. But what happens if there is no cochlea? I said 99% of children who have sensitive hearing loss have problem in the cochlea, and this is correctable with a cochlear implant. But in 1%, there may be not in the cochlea but beyond. For example, children who have no cochlea at all at birth or cochlear nerve at birth. Can hearing be restored? Now, this is where auditory brainstem implant comes in, where we put a chip in the brainstem in the auditory area known as the cochlear nucleus, and we can restore hearing. So this is surgically implanted, and this is kept in the lateral recess of the fourth ventricle in the brainstem. It's also helpful in neurofibromatosis type 2, where they have bilateral tumors, and removal of tumors will mean sacrificing the cochlear nerve. The implant is a small chip. It's kept in the fourth ventricle, the lateral recess, and it stimulates the cochlear nuclei. So basically, it is done in children who have no cochlea or cochlear nerve. It's also done occasionally children with severe meningitis causing ossification of the cochlea where an implant is not possible, or bilateral temporal bone fractures and so on. Now, this is a scan of a child who has no cochlea at all and no cochlear nerve. So here, obviously, you can't do a cochlear implant, and the brainstem implant is the only option. That's the picture of a brainstem implant, and this is what the surgical intraoperative picture looks like. The first recipient of a brainstem implant in India was a girl who was about 14 years old who had bilateral acoustic tumors, vestibular schwannomas, which were removed and then an implant was kept in. She was also the first girl in whole of South Asia, and the first pediatric brainstem implants were done in Chennai, in the whole of Asia, in the whole of Southeast Asia, and Asia Pacific region. Today, we have almost 100 children who have received pediatric brainstem implants. It's one of the largest numbers in the world. We are one of the largest series in the world. And, these children have got back their hearing. May not be as good a result as in cochlear implant, but still they can develop sufficient language and speech. So here are performance of children with who received brainstem implants.
E. Hi. Okay. What is her name? Hi, months of the year.
Months of the year.
Oh, January, February, March, April, May, June, July, August, September, October.
So they can develop speech, may not be perfect, may not be as good as a cognitive implantee, but still they can develop sufficient speech to get into a normal stream like other children. Of course, newer developments are happening. We are now even going higher into the midbrain, And I wanted to talk a little bit about the cochlear implant program in Tamil Nadu. It's one of the most successful programs in the world. To date, more than 5,000 children have received cochlear implants in Tamil Nadu alone. It's one of the earliest programs in the country. Every medical college in the state of Tamil Nadu has got a cochlear implant program, and it's probably the only state where every district has got a cochlear implant program. And we are also thinking now about universal neonatal screening. In fact, yesterday I launched a program in one of the districts where universal neonatal hearing screening is started, where every child born in that district will be screened on on the first day of birth or second day of birth before the child is discharged home. This is an imperative thing. This is something which we have to do in the whole country. This is standard, it is a norm in every advanced developed part of the world, and we are lagging behind. If we pick them up early, then we can diagnose them by 3 months of age, and by 6 months we could have fitted a hearing aid, and at least by 1 year we could have intervened. If we can do that, then every deaf child would have got normal hearing and language and could become a person of somebody of worth in the future. We are now looking at bilateral implants simultaneously and also in middle ear implants. So, to conclude, we have advances in biomedical engineering and neural processes which have greatly helped in rehabilitation of hearing loss and helped make the transition from a world of silence to the world of sound. Early detection and management of hearing loss is extremely important. It has an impact on the language and speech acquisition and overall development. Universal newborn hearing screening is crucial. In all children with congenital hearing loss, a complete audiological evaluation, imaging, and assessment for syndromic etiology is mandatory. With early diagnosis and proper intervention, a child born with congenital profound deafness can be expected to lead a normal life as a productive citizen. Increasing awareness regarding diagnosis and intervention, avoiding consanguineous marriages will all help in reducing the burden of deafness. Thank you all very much for your patient listening. I am open to questions.
Thank you so much, sir, for your wonderful presentation. We do have some question if you like to take that up.
Yeah,
Yeah. So, sir, the first question was, what are the current diagnostic tools and technique used to detect hearing impairment in children at the early age?
right. So, we have a whole lot of tests today which can be very helpful in very early age, let's say soon after birth or within the first month. Here, you cannot expect the child to cooperate with you for testing. So you have to have objective tests where you don't have the cooperation of the child. So one of the earliest tools we use is known as autoacoustic emission, where we can screen the child for hearing loss even at birth. It's a very simple tool which will give you a result within a minute. And it will tell you whether the child has passed or failed. It's an ideal tool for screening the child, and it gives you a pass or a fail. If the child has passed, most likely has got normal hearing. If it has failed, it does not mean it's got a hearing loss. All that it means is that you have to put the child through further tests. So if a child fails, then ideally we ask the child to be retested again at 1 month of age, because things like some meconium in the middle ear or little fluid in the external ear can affect the test. So we redo the test after a month, and if the child again fails, then we put the child through a proper test battery, and this will include subjective tests where the child responding to sounds, BERA, or what is known as auditory brainstem responses, auditory steady state responses, and so many tests, LLR and so on. So basically, all these electrophysiological tests which record the waves in the brain in response to sound, and we can assess the hearing and we can come to a reasonable conclusion. In addition, of course, if we diagnose hearing loss, we also have to have imaging and assessment by other specialists, as I told you, to rule out any syndromic association.
Thank you, sir. The next question is: how has the role of cochlear implants and hearing aids evolved in managing childhood deafness, and what are their limitations?
The, uh, the the answer is very simple. It has completely revolutionized the management of hearing loss. So if you pick them up early, and before by 6 months you start intervening, and by 1 year you have corrected the problem, then this child will have a normal life. If you delay this beyond 3 years, then the child will have, some defect or deficit all through a mild handicap. After the age of 6, it becomes useless. So age is very, very important intervention. So there's no doubt at all that hearing aids and cochlear implants have completely revolutionized the management of hearing loss. What are the limitations? The main limitation is that it's time sensitive. So if you're going to intervene, you have to intervene at the right time. Sorry. Delayed intervention is no use. So if your child is brought to me, and this happens unfortunately in our country, somebody brings a child at 12 years, 15 years, and then suddenly a child is brought at the age of 17 or 18 because the father suddenly realizes he has to get his daughter married, and nobody will marry a deaf child. So then he brings it. It's too late. We can't do anything at that stage. So time sensitive. We have to be very, very early. This is why early diagnosis and intervention is extremely crucial.
So there's one last question. Um, what further technologies or innovation could revolutionize the ways we approach prevention, diagnosis, and treatment of childhood deafness?
Yeah, I think one of the biggest developments which is happening is in the field of genetics. Today we have identified genes which are specific for hearing loss. We are able to screen. We have also genes which tell us which are the ones who are going to do well with cochlear implants, which are the ones who are not going to do well, because it depends on the neuronal population. We can say that this particular gene, if you have, is a cause of hearing loss, and this person with the cochlear implant will do very well. Or if somebody has this particular gene, they're not going to do very well. So we can actually identify the cause of hearing loss with the gene. We can also prognosticate. And the other big development which is happening is because we know which gene is the defect, we can also start thinking about intervention in the form of gene therapy. This is already happening in some specific genes where we have been able to correct the problem with intervention by gene therapy. But there's a lot of scope. The future is still very bright, and I think this is going to be one of the most significant developments which is happening over the next 2 decades.
Thank you so much, sir, for answering all our questions. That's all from our audience. Before concluding, sir, any take home message from your end?
Yes, my only take home message is as physicians, you all have a role in early diagnosis and proper counseling. Pediatricians, family physicians, they're all extremely crucial people. So when a child is suspected to have a hearing loss, please, emphasize to the family the need for early diagnosis. Let them not sit on this saying that, oh, it'll correct away. This is all, usually there's a denial. And they say, oh, father spoke late, my grandfather spoke late, so let's wait for one more year. That's the biggest mistake they can make. So, as physicians and family physicians, as pediatricians, your role is crucial. So, you have to advise them, look, don't wait, go and get your test done. It may be good, it may be bad. If it is good, fine, nothing is lost. If it is, there is a defect, then your early diagnosis is going to make a whole lot of difference for this child's future. So your role is crucial as counselors for the family. They trust you. Your advice is crucial, and you are people who can make a difference.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session. Thank you
Thank you
so
so
much.
much. Thank you.